All right, good morning, everybody. Good morning. Thank you. Thanks for coming to Grand Rounds. Thank you for coming to the September edition of Grand Rounds. Today we have Marlee McNerney talking to us about clinical management of spinal cord survivors and some updates on spinal cord injury management. She went to for her Master's of Occupational Therapy at Alvernia and works in our acute rehab center. Just some housekeeping, make sure you sign in, and anybody from New Jersey, make sure you also sign out. There is a separate one for New Jersey. And make sure you also pick up a feedback form and drop it off, please. And then pick up your certificate. And everybody online, make sure afterwards you email me for a quiz. All right, without further ado, turn it over.
Okay. Hi, everyone. Thanks for coming. Can everyone hear me okay? Just want to make sure I know how to use this. Okay. So my name is Marlee McNerney, and I'm an occupational therapist at our acute rehab center. Prior to working in our acute rehab center, I worked for our acute care setting as well. And in acute care, I worked in our neuro ICU, where I saw many patients who had spinal cord injuries. And now I've since worked with patients who have spinal cord injuries in our acute rehab center. So this morning we'll be discussing the clinical management of spinal cord injury survivors. And I became very passionate about this topic and about this patient population. And through working with them, I discovered that there was some improvements that could be made to our whole network for how we can treat these patients. So that's what this is going to go over. No financial disclosures. So goals of this presentation include evaluating the current best practice for spinal cord injury survivor management from a medical and physical and therapy standpoint, identifying appropriate equipment to be utilized with this patient population, discussing how to prevent the adverse medical conditions that are often commonly related to spinal cord injury, identifying the interdisciplinary team that is critical to the success for these patients, and understanding a little bit more about autonomic dysreflexia. So just some background on spinal cord injury that you guys already know, but the spinal cord injury is an injury of the spinal cord from the foramen magnum to the cauda equina, which occurs as a result of compulsion, incision, or contusion. The most common causes of spinal cord injury in the world are traffic accidents, gunshot injuries, knife injuries, falls, and sports injuries. Something to point out too, there are two types of spinal cord injuries that you've seen here in our setting. So traumatic, which is I think what we think of the most common and what the statistics describe there. But then there's also non-traumatic spinal cord injury. So that can happen by a tumor or an abscess. We have patients who come with these as well, but they present in the same way as a traumatic spinal cord injury. I want to talk a little bit about, so I saw that as one of two level 1 trauma centers in the Lehigh Valley at St. Luke's, and as St. Luke's continues to expand, we've had patients transferred into us from some of our smaller hospitals, and we've seen an increase in the number of patients with a spinal cord injury who have been here. So as this number continues to grow, it also talks about why this is so important for us to have a better understanding of how we can best help these patients. These are some neurosurgery guidelines. So these came from Jessie, who's our lead neurosurge PA here, and she had talked with Dr. Moulding about, kind of this is the process that they go through from a neurosurgical standpoint. So if a patient presents and there's a suspicion for a spinal cord injury, then they do a stat MRI and pre-op labs, and they're admitted straight to the ICU. Their goal is to be taken to the OR within 24 hours, and that's most likely the day of their admission. For the first week post-op from their surgery, they must maintain a MAP, which is a mean arterial pressure score, of 85, and this often requires an increased ICU length of stay. Their aggressive OT and PT services begin often post-op day 1 if medically appropriate. Cervical and thoracic bracing lasts for about 6 weeks, and they obtain upright x-rays immediately and then prior to their discharge. So talking a little bit about an interdisciplinary team, we know that this is so important through our physician teams, through our therapy teams, through our nursing teams, our restorative specialists, and having a strong interdisciplinary approach for all patients is extremely important. But I want to talk about some different services for this specific patient population. So normally OT and PT are always consulted post-op, and then speech therapy is consulted normally post-op if swallowing is an appropriate assessment or they're having deficits with swallowing. But we can also ask or talk to our speech therapists and our physician teams about consulting speech therapy for deficits in communication, even if these patients aren't able to swallow yet, like for example, when they're on the vent. Neuropsychology. This is something I don't think that maybe everyone knows, but we have neuropsychologists who partner at our St. Luke's Bethlehem campus, and they're able to receive consults for patients to provide psychotherapy services after traumatic or life-altering events. So as soon as these patients are able to communicate, even if that's not verbally, which we'll talk about a little bit later, but this is a consult that's so important. They help our patients in discussing different patients and families in discussing coping strategies after this event, which is normally a completely life-changing event for these patients. A research article found that depression is the most prevalent and disabling psychiatric comorbidity after a spinal cord injury, and that major depressive disorder occurs in 25 to 30% of community residing persons with spinal cord injury. In this population, the depression tends to be persistent and is often associated with the development of pressure ulcers, UTIs, poor self-appraised health, less community mobility, and participation in social and leisure activities. However, even with this number being high, only 29% of those people who have major depression disorder are treated with an antidepressant, and only about 11% of those patients receive any type of psychotherapy counseling services. So if you're asking for a psychotherapy consult, what you would ask the physician team to do is to place an order for neuropsychology and then comment in that order and say that this was for psychotherapy or coping after a spinal cord injury, something along that nature, so they know that it's not for a capacity evaluation, which is the other thing that our neuropsychologists are often a part of. And then physiatry, or PM&R, I think that this is really growing, having these consults. But so this is our physician team who works in the acute rehab center and who specializes in rehabilitation. And something to point out is that spinal cord injury rehab should really be starting in our ICU setting immediately. Our physiatry team is a big part of this. They assess and can help provide the other physician teams with medical management that is appropriate for spinal cord injury, so like bowel bladder management. They perform our ASIA assessments. They help determine the need for a dedicated spinal cord injury rehab or not, and they're a really big part of our team. So I think that as this is kind of growing and there's been some more physician education on consulting neuropsych and physiatry and speech therapy for communication, this is something that as OTs and PTs, we're often the disciplines that are automatically consulted. So it's good for us to keep an eye out and say, like, are these disciplines also appropriate? And if so, talk to the physician team about placing an order for them. So complications after spinal cord injury. The results of a spinal cord injury bring not only damage and independence to physical function, but also include many complications: neurogenic bowel and bladder, urinary tract infections, pressure ulcers, orthostatic hypotension, fractures, DVTs, spasticity and autonomic dysreflexia, as well as pulmonary and cardiovascular problems and depressive disorders are frequent complications. And we're going to review some of these barriers now. So neurogenic bowel and bladder. Depending on the level of their spinal cord injury, neurogenic bowel and bladder function is a huge medical and rehabilitation barrier. Bladder management normally occurs with a Foley or straight catheterization. From a therapy standpoint, in rehab and the acute care setting, it's important to touch base with nursing and see what their process is. For example, like straight catheterization could take anywhere from 10 to 20 minutes for this patient. So you want to plan accordingly to what's happening there prior to seeing them for therapy. Something that I commonly noticed is kind of from an impaired or neurogenic bowel standpoint, what would happen is that these patients experienced constipation, which then, after not going to the bathroom for days at a time, was followed by some type of intense bowel regimen that led to loose stools for a longer period of time. Now, this would often be seen during rehab and during the mobilization of our patients, which is embarrassing for them. So they would then start to associate getting out of bed or working with therapy with having an accident, having to be assisted back into bed, having to have staff help them be cleaned up after an accident, and that would create a barrier for them wanting to participate in therapy. Additionally, incontinence of bowel or bladder increases the risk for skin breakdown, and then if skin breakdown is already present, increases your risk for infection. So consulting, this goes back to consulting our physiatrists and PM&R team to provide guidelines that are more specific to neurogenic bowel and bladder, because it is a different experience than, say, patients who are experiencing constipation after a post-op, joint surgery or because of pain medication. And I think it's an important note too that, like, as patients go through their rehab course and we work with them for therapy, even if we made physical gains, like if this is not addressed, then their quality of life is not, is severely impaired, which is why this is such a big impact on it. So talking a little bit about skin breakdown and pressure ulcers. Pressure ulcers can diminish global life quality, and they contribute to rapid mortality in patients and pose a significant cost to the healthcare system. So in the United States, pressure ulcers cost an estimated $1.6 billion a year. And I want to talk a little bit about, what does cause skin breakdown in patients who are with spinal cord injury or spinal cord injury survivors. So one that we just mentioned was impaired bowel and bladder or incontinence. And then limited mobility. Mobility poses a challenge because often these patients, even initially, require 2 or more people for repositioning in bed. So what can we do to help prevent skin breakdown and these adverse complications? I'm going to talk about utilizing appropriate equipment for these patients to help prevent, not necessarily in response to, but really trying to prevent skin breakdown from happening. So patients who are not mobile may be appropriate. They're not appropriate to be out of bed, or they might only be able to tolerate a small time out of bed, and the majority of their time is spent in bed during the day, would benefit from an air-inflated mattress. At the Bethlehem campus, the 2 that we normally use are the Craig Catalyst bed, which allows for tilting of our patients, which also assists in blood pressure and respiratory management. And this is what was most commonly used, I feel like, for our patients who have complete or incomplete cervical or thoracic spinal cord injuries, at least initially. If the patient would not benefit from tilting or is not appropriate to tilt, like they were also non-weight bearing to their lower extremities or something, then the P500 air mattress we've used for skin integrity purposes. Big key, and we all know this, is repositioning every 2 hours in bed. So up here, this is a clock, a turning schedule that could be used and utilized in the patient's room to help people keep track of, what time someone should be laying on what side, and then we know that the 2-hour repositioning is happening. We have the green wedges here that can be ordered from the storeroom and should be ordered from the storeroom from these patients to help them completely offload on one side, and then using pillows for comfort for them as well. Prevlon and multi-potus boots can be ordered to prevent skin breakdown, or in the case of foot drop is when we'll often see the multi-potus boots ordered, and it's everyone's job. Sometimes these are ordered initially before therapy is even present. If not, our physical therapy team also does a really good job at looking at if these patients are at risk for foot drop and asking for their orders as well. So talking again about appropriate equipment. The first question to ask is this person appropriate to be out of bed? And then the follow-up question should be, what is the safest method we can use to get this patient out of bed? So this is a picture of the B-mat. This is something that our nursing staff utilizes here and was created by Duke University. This is an image of it, and you can receive more images they have a really nice handouts online at their safety.duke.edu that kind of guides you through how to use the BMAT. But it's a medical and mobility assessment that was created for nursing to assist in determining the safest methods for transferring patients out of bed. If you noticed, first they always they perform a safety screen to assess if the patient is even medically appropriate to transfer out of bed. If they pass that, then the next step is their sit and shake assessment. So if a patient cannot sit up at the edge of the bed and shake your hand without physical assistance, then they recommend for repositioning in the chair position or repositioning bed or using equipment for out-of-bed transfers. So in my experience, honestly, I can't think of any patient who would have initially passed this assessment, but frequently we don't utilize any equipment to then transfer them out of bed. So kind of talking about a change of practice from our standpoint. The most appropriate for especially our patients who have cervical, complete or incomplete injuries, and even thoracic is often here the Hoyer lift that we have access to transfer these patients into bed as the safest method for our staff as well as for the patient. So then say that your patient is appropriate or can tolerate being out of bed. They are at risk, as we know, for skin breakdown if they can't perform a weight shift. So an ideal weight shift would be every 15 to 30 minutes for 90 seconds. If your patient cannot easily weight shift themselves by sitting and completely offloading one side of their bottom, or easily stand with like assist of one staff member for about 90 seconds, then we should be looking at different seating devices for them to use. So often here we utilize our tilt and space wheelchair. I found that this is the best outcome for promoting frequent weight shifts and as well as decreasing our staff burden. And therefore, we carry over the weight shifting program better as an entire staff. As therapists, we know that high back wheelchairs can be used for a manual weight shift as well. But I think that when you look at the time it takes for staff to perform, as well as the comfort that's needed to do that, as well as the risk if it wasn't performed safely, the tilt and space wheelchair is our best option. The Paralyzed Veterans of America Association puts out different spinal cord injury guidelines, and one thing that they make a point of is that employing a power weight shift system when manual pressure redistribution is not possible is something that's necessary for these patients. Another reason I really like using the tilt and space wheelchair is it allows for better blood pressure regulation and management of these patients. So sometimes they can tolerate being out of bed for a longer period of time. So if you have a patient who has skin breakdown or is at risk for skin breakdown, requires a tilt and space wheelchair, then the other thing that we should be looking at is what seating surface or cushion is appropriate for them. So a RoHo cushion would be ideal. If there is no RoHo cushion available, our gel cushion could be used as a backup choice to be positioned on the seat, because we know that skin breakdown is costly and such a huge barrier to these patients. One thing I wanted to point out was we have a pink chair at different places in the hospital that's sometimes utilized, and it's a really good tool to help dependently transfer patients out of bed. It's easy to use for staff, but it's often not really an appropriate seating surface to be utilized, which is why I know that as a network, in the Bethlehem campus, we've accrued multiple tilt and space wheelchairs that could be utilized instead. So talking about this, I feel like when we look at this patient population, using like an assist of 4 or more people to transfer a patient out of bed is not really going to be a safe transfer unless it was using something like the hover jack or the Hoyer lift where multiple people are involved in managing the equipment. It really increases our risk of staff and patient injury as well. Also, our patients who that experience doesn't go well for, they're very scared, then end up not wanting to mobilize out of bed because it was a bad experience for them. So I think that having a plan such as using our hover mat or our Hoyer lift is the safer option. And I know that initially when I had to do this a few times, I would call on people like our management team, John Stone, who is more familiar with the equipment, to come and help me utilize it so that I could feel more comfortable with it and provide the safer plan for our patients. Another note about being out of bed is for this patient population, our patients may only be able to initially tolerate 10 to 20 minutes of out of bed. So it's not unlikely that during the therapy session, we would get the patient out of bed, do something therapeutic with them while out of bed, and then help them get back into bed initially, because medically, blood pressure, respiratory related, this was all that they could tolerate. Our therapists, it's critical that we work with our nursing staff to monitor the patient's vitals and tolerance to out of bed prior to just leaving these patients out of bed, you know, when we leave. So often when I'd work initially with physical therapy, we'll get the patient out of bed, see how they do. Our nurse will be present. We'll assess all of their vitals and determine, you know, do we need to get this patient into bed in the next few minutes, or do we think that they might tolerate being up for 30 minutes to an hour? It's everyone's job to participate in weight shifting once these patients are then out of bed. So our therapy staff, our nursing, our restoratives, everyone should be trained on how to perform, say that we're using the tilt and space wheelchair, you know, on how to safely perform the tilt and understand that the weight shift is, you know, every 15 to 30 minutes for 90 seconds. For some patients, we've used timer schedules to help promote this. So in our patients who are cognitively intact and can carry this over, I'll educate this to them a lot. Okay, you know, about every 20 to 25 minutes, I'm going to set this timer for you. When it goes off, I'd like you to call for help. When you answer your call button, come in and tell someone that you need to be shifted in the wheelchair. For our patients, or we've had family members who have done this too, which is a big thing. Like, our family members are appropriate and they can demonstrate that they're able to do that, then that's great because they can help our patients. Going a little bit more into adaptive equipment, I want to talk about different types of call buttons to use. So our patients who have experienced quadriplegia or quadriparesis are not normally able to utilize our standard call button initially, and we still have to make sure that their communication needs are met. So I've had a few patients here who have had complete quadriplegia, and, you know, really the movement that they have is minimal head tilt. Prior to conducting our evaluation, it was really hard for, you know, there wasn't really a way for them always to be able to communicate. So I'd like to just take a minute and think about that. Like, not only are these patients not able to change their TV channel, they can't reposition themselves, they can't scratch an itch, but then they also can't call for help to have someone do these things for them, which is just a helpless feeling that I can't even really imagine. So our nursing staff in the ICU is great, and they often will help set up, you know, if before even therapy's in there, try to use our adaptive call buttons. But this is something that from OT I would write a goal for. It's within our scope of practice that the patient will communicate 100% of their needs required for ADLs with the use of adaptive equipment to increase autonomy and participation in ADLs or leisure activities, something along those lines. Talking a little bit about types of buttons we have the gray squeeze buttons that can be used, but our patients have to have some type of digit flexion in order to do that. And more often we would utilize the blue panel switch buttons. But in the case of, again, complete quadriplegia or quadriparesis, this would often we'd have to use near their head so that they would be able to tilt the call button using a little bit of neck lateral flexion. And I've had certain OT treatment sessions that have really focused on them being able to do that. And then we talk to our nursing staff or leave notes on the whiteboard so that everyone would know what is the best position for this. So these have clips, so they should be clipped to the pillow, you know, touching the left side of their hair sometimes. That would even be it. It would have to be that close for our patients to just gently tap the button and be able to then call for help. And then something, so remember that it's not uncommon for our patients who have experienced a cervical spinal cord injury to have initially undergone a tracheostomy or be on the vent during their ICU stay, which then limits their verbal communication as well. These patients are often able to move their lips, but not everyone, not our staff and not their families are good at lip reading. So one effective way of communication that I learned from our speech therapist was look up, look down instead of blinking for yes/no questions, because blinking can be an automatic response. So I would tell a patient, I would use this to generally assess like orientation and cognition. So I would say, look up for yes and down for no. Are you at St. Luke's Hospital? Are you at Thomas Jefferson Hospital? Is the year 2016? Is the year 2018? to get an idea of kind of what we were looking at from a cognitive standpoint. This method is effective, but it limits our patients to communication to yes/no questions. So having to say, are you in pain? Are you repositioned? And we kind of go through a series of questions in order for them to get out, you know, what it is that they want or need. So talking about a different method as well, one time I worked with a patient who was in her 40s. She had a traumatic cervical spinal cord injury that left her with complete quadriplegia. And upon arrival to a room, I was stopped by the nurse who came up to me and said that the patient was being very frustrated. Her family couldn't communicate with lips. They couldn't do the lip reading. She couldn't use the call button. They couldn't find a position that worked best for her to do that. And her young children were coming to visit her later that day. And she was really upset and had a lot of anxiety about this and didn't know how she was going to be able to communicate with them. So I spent about a 45-minute treatment session working with her on lateral neck flexion so that we were eventually able to put the call button, like I said, very close. It actually had to touch her hair and be clipped so it would touch her hair on the left side of her skull, but she was able to then tilt her head a little bit so she could call for help. Then the other part of the session that was spent was creating a communication chart. So a low tech eye gaze communication chart is something that could be used for patients who are cognitively intact enough to use this to help promote their autonomy better. So I'm going to demonstrate kind of how this is. All I did was take a manila folder, which was easy to find. It was already on the floor, and I cut out the center of it. I then worked with the patient. So there are certain things that I recommended that the patient use, like pain, reposition, TV on off, yes or no, check for autonomic dysreflexia, which is something that we'll talk about a little bit later. But when I asked the patient what words she wanted to communicate to staff, the words that she wanted to be on the chart were scared, anxiety, feels like I can't breathe, and TV volume up and down, which I think is just another example, like when she said those things, that really hit me as to obviously how she was feeling, how helpless that must feel, and I think is a good example too of why it's so important to have our neuropsychology team involved in the coping of these patients. But I'm going to have a volunteer. So you want to come up since you're in the front. Come up and talk about how to utilize this. So what I did was use the words that she wanted. So we had yes, no, TV on, off, anxiety, feels like I can't breathe, set up as different options for her. And then I instructed her, so what the important thing is to make sure that it matches what you're looking at, matches what's on the back. So I would write no here and then directly flip it over and write no on the other side as well. So to say with my patient, I came up to her like this and I said, okay, and this hole could be even smaller. I mean, this one kind of big, but I say, okay, you're going to look at me and then you're going to look at what you want. So she looks at me, and I went, yes. Looks at me, no. Okay, it was really simple and it was easy to use, but it allowed us to go through more. It allowed us to have more options than our staff to have to run through. Are you uncomfortable? Do you want the TV up? Do you want the TV down? And her looking up and down for everything. This gave her a lot more autonomy, and then she was able to communicate better with her family as well. So that was a really good tool. And then I trained our nursing staff, our PCAs, on how to utilize this with her so that she could have increased communication. And then another thing that we ended up doing was she did get, this was a very basic thing, but I had talked to the physician team about getting her a speech therapy consult, and then they did see her for communication as well. They have other tools that are very effective that they utilized. So kind of going about adaptive equipment too. Another adaptive equipment for feeding is something that we often utilize in occupational therapy. So that's another goal that I would make for these patients if it was appropriate to complete self-feeding at a supervision level with use of adaptive equipment as needed. We'd often use our built-up utensils or a universal cuff and spend treatment sessions working with patients like that, which is another good tool. So sometimes we would transfer the patient out of bed, work on feeding, while out of bed, and assist the patient back to bed. And then I think this is pretty common, but alarms. So even if our patients are cognitively intact, they are high fall risk if they are out of bed and anything should happen while they're in the wheelchair, you know, it's important that we have them alarmed, on alarms. Okay, so talking a little bit about blood pressure regulation. So a spinal cord injury results in significant morbidity and mortality. We've talked about this, but it's a standard now of spinal cord injury care is improving neurological recovery by reducing a secondary injury. And to minimize secondary injury, blood pressure augmentation has been advocated for. So what I talked about in the beginning of this presentation is that our neurosurgical protocol is that for the first week post-op, our patients have to maintain a mean arterial pressure score greater than 85, which often requires our patients to have an increased ICU length of stay. Patients who are initially post-op often have an arterial line that's measuring their blood pressure. So what we need to know about this from a therapy standpoint is that that line needs to be zeroed out anytime that there's a change in position. So it's a, you know, our nurses are present and we communicate that to them too. It's not, if you take a patient at the edge of the bed and then stand them, the blood pressure reading won't be accurate because there was a change in position. So we would instead use the automatic cuff reading and then have our nurses would come in and zero out the lines once they were in the position that they were going to be in for a period of time. So talking about a MAP score, actually, I think Jim was the person who first explained to me, who's here, Jim and Anna are ICU nurses, what it meant, like, and why it was so important to have a mean arterial pressure. So mean arterial pressure is a useful concept because it's used to calculate the overall blood flow and thus deliverance of nutrients to our vital organs, which therefore means that a low MAP score would mean that there's not enough blood flow that's getting to our other organs. When progressing a patient through mobility, it's important to monitor their vitals and assess as the position changes. So you're looking for orthostatic MAP scores or possible autonomic dysreflexia based on their blood pressure readings. So a blood pressure should, at least initially when a patient's being mobilized for the first few times, should be taken while lying down, while seated upright in bed, while at the edge of the bed, while in stance, while out of bed. This is especially within the first 7 days where neurosurgery says our MAP scores are so important. If the patient also, or another, if our patient has, even if you're working with a patient not post, out further from post-op, and you know that they've had barriers with blood pressure, this is something we need to continue to be assessing. And is a really big part of this is communicating with our nursing staff as well as our physician team. So if a patient is experiencing orthostatic hypotension consistently, if they can't maintain their appropriate MAP scores, then this is something that our nurses are aware of, and we're presenting to our physician team is what can medically be done with this. So should orthostatic hypotension occur, you can speak with the physician team to see if it would be medically appropriate to order TED stockings or an abdominal binders or ACE wrap on the legs as instead of TED stockings. If that's medically appropriate for them to order this, which would assist our patients in tolerating out of bed or sitting up for a longer period of time or during tilting with these patients. If this was medically appropriate and they did order them, then this would be used when the patient was mobilizing or was sitting up, and then would be taken off at night if it was only being used for blood pressure purposes to help promote good skin integrity. So another barrier, autonomic dysreflexia. I think that this is one of the most important things in this whole presentation. So probably if I've treated about 100 treatment sessions today with patients who are spinal cord injury survivors, only twice has this ever happened where I experienced a patient having autonomic dysreflexia. But when it occurred, not everyone that was present was aware of what was really happening or knew exactly how to handle it. And when I was researching for this presentation, that was something that commonly came up. And actually, a lot of the handouts for spinal cord injury survivors is having them be able to advocate for themselves what is happening, because autonomic dysreflexia is not something that is well known in the medical community because it's more rare. But it's dangerous, and it's a serious medical emergency when this happens. Talking about it, one of the research articles said, autonomic dysreflexia is an emergency situation. It's an abnormal response which occurs when your body is experiencing pain or discomfort below the level of your injury. Because the pain or discomfort message does not get to the brain because there's an injury to the spinal cord, the body's blood pressure increases to dangerous levels. If the cause of pain or discomfort is not found and treated immediately, then serious complications such as stroke, seizure, organ damage, permanent brain injury, and death can occur. So our patients who have a T6 spinal cord injury or higher are our patients who are at greatest risk for having this happen. And then T6 to T10 are at a moderate risk of having this happen. So something that's so important to talk about are the signs and symptoms of autonomic dysreflexia. So they include a severe and pounding headache, goosebumps or chills, sweating, bradycardia, changes in vision or blurred vision, dizziness and nausea, rapid breathing, anxiety, and flushing of the neck or face. Also, according to the Paralyzed Veterans Association, it's important to note that a patient may also experience silent autonomic dysreflexia where they have limited symptoms, but their blood pressure is continuing to rise. So what causes autonomic dysreflexia? The most common causes are problems with the bladder. So if this is happening, you want to check to see if the catheter is kinked or see when the last time the patient was straight cathed. This problem can occur as well because of a UTI or because during a straight catheterization, the patient isn't able to fully empty. Bowel is another cause of this. So you want to check for bowel incontinence or constipation. And then irritants to the skin. So immediately remove or loosen the articles of clothing. Check for objects that could be irritating the skin. So that could be something that might be left in the bed, part of their wheelchair cushion. Ingrown toenails or pressure ulcers can also cause this to happen. So if you're working with a patient and any of these symptoms occur, not all of them, not at least 3, any of them, then you immediately need to get nursing involved if they aren't already present. Check their blood pressure. So autonomic dysreflexia and orthostatic hypotension may be confused by a medical professional because some symptoms could be similar, but the course is very different. So if you have a patient and you get to the edge of the bed and they start to say, like, I don't feel right, my head, doesn't feel okay, then we should be asking them specific questions. So do you have a pounding headache? Do you feel dizziness? And start kind of going over what those symptoms are. At the same time, we should be assessing their blood pressure to determine if this is a higher reading or a lower reading than what we had initially obtained. So for obviously higher blood pressure, then we're looking at more possible autonomic dysreflexia situation. If their blood pressure is severely dropping, then we're looking at more of an orthostatic hypotension situation. Then you need to, so say it's determined that this is autonomic dysreflexia, their blood pressure is really rising. You need to assess what stimulus is causing this. So you check for any problems with the bowel. I think it's helpful because you might have to lie the patient down, check that, and then you immediately try to sit the patient as close to 90 degrees as possible. I think that's the big difference in, so when I had this and this was happening, people were like, oh, well, we lay them down, they're getting dizzy, this is orthostatic hypotension, but it wasn't actually, so we had to sit them up immediately. You reposition and check for skin irritants, loosen or remove all articles of clothing, check the catheter to see if there was a kink, talk with nursing, see when the last time the patient was straight cathed, they need to be bladder scanned, and then you continue to monitor their blood pressure every 3 to 5 minutes. Also, as this is happening, we should be notifying, as we're going through and checking all of this and trying to find the stimulus, notifying the physician team that this is happening in case we aren't able to resolve this immediately. So like I said, research supported that a general lack of knowledge that exists on this topic in medical professionals and healthcare providers. And so we should be educating all of our staff and patients, if they're cognitively appropriate to understand this, on what the signs and symptoms of autonomic dysreflexia are and how they should instruct their caregivers to help them, should this happen. Also going over this with family members and caregivers is important as well. So if I had a patient who was at risk for autonomic dysreflexia, then what I started doing is going over this with all of our nursing staff, our PCAs, people who might take this patient and work with them after me and say, this patient's at risk for this. These are the signs and some symptoms we need to be careful for, and this is what we need to look out for. Our physiatrists, when they are consulted in the acute care setting, will make, in their consult, they'll have like a list that describes that. And I've even made like a smart phrase or put it in the sticky note so that our treatment team, anyone who accesses it, can just get a quick blurb about what it is, what symptoms should occur and what they should do. I think it's important to remember that our patients, especially patients who experience a non-traumatic spinal cord injury, after their stay in the ICU, could be transferred out to multiple different floors of the unit where our nursing staff might not be familiar with this as much. And again, just remembering that autonomic dysreflexia can be a life-threatening condition. Okay, so kind of to just summarize things that we talked about. Spinal cord injury is a complex diagnosis that impacts the patient's medical, physical, and psychological well-being. There are multiple medical and therapeutic considerations that need to be taken into account when we're working with this specific patient population in acute care, acute rehabilitation, all therapy settings that help promote best patient care. However, medical professionals might not be as aware of the specific needs that are required for this population because it is not a diagnosis that is as commonly seen, especially in our complex spinal cord injury. At our Bethlehem campus, I was able to work with our neurosurgery team, trauma, critical care, therapy, nursing, physiatry, wound care, and rehab to come together and create a spinal cord injury clinical pathway, which was an order set that the critical care team then was able to develop. That's kind of based on the information that we covered. So how at Bethlehem we have a stroke pathway. What it does is it allows our physicians to go in and have easier access to know what consults are more appropriate specific to this patient population. What bracing, it included bracing, different activity orders, therapy orders, neuropsychology, physiatry, and it is hopefully a stepping stone so that this information is all hit. And it helps us make sure our patients are getting the best care that we are able to provide. However, we need to work as a team to ensure that our patients are receiving the best care here. So to summarize, OT and PT are normally consulted, but speech-language pathology can be consulted not only with deficits in swallow, but also for communication. A physiatry consult helps promote our rehab recommendations, medical management that are specific to a spinal cord injury population. Often a good example is Neurogenic, Bowel, and Bladder. Perform our ASIA assessment for these patients. A psychotherapy consult, once our patient's able to communicate, even if it's not verbally, even if it's using something like this eye gaze chart or look up, look down, it helps our patients cope after this traumatic life-altering event. As therapy teams and nurses, we should be checking for our bracing and activity orders. Our bowel and bladder management is critical to a patient's participation in therapy as well as to their overall quality of life. We need to make sure that our patients have the basic right to communicate their needs and ask for help, and often this is using adaptive equipment in ways that are different than normal, like I said, including head tilt. Blood pressure regulation and management should be assessed by nursing, therapy, and working with our physician teams and as a team together to determine how can we help this patient engage in what they need to do while maintaining appropriate blood pressures. All staff, caregivers, and patients who are at risk of autonomic dysreflexia need to be aware of the signs and symptoms of it, as well as know how to respond to this life-threatening event. Something, too, that I want to point out is this is really the standard of care that we should be striving for with our spinal cord injury patients. I think that this is some information that is new, but it really is the basic care that we should be providing, although it is different than what we have to provide for our other patient populations. And then I'd like to just take a minute and talk about two of my favorite moments as a clinician. So one was when I was working with a male who was in his 20s, and he presented with a traumatic, incomplete cervical spinal cord injury. We worked with him for about 7 to 10 days prior to him being sent to a dedicated spinal cord injury rehab. So on his evaluation, he was a pretty much a total assist of 2 of us to do a sit pivot transfer for him. He presented with limited use of his upper extremities. We were trialing adaptive equipment during feeding and his occupational therapy sessions. Over the 7 to 10 days, he was able to then do a essentially max assistive 2 stand pivot transfer to a tilt and space wheelchair, and that was then when he left us to rehab. So getting to one of my favorite parts was about a month after he was discharged, he came back to visit us, and he was walking, independently, using a walker, but walking around the whole hospital. And I just thought that was really cool to see. And he came back and thanked the therapists and the nurses that had been working with him. So it was really nice to see his progress. Another favorite moment of mine was about 3 months after I had worked with a patient who came in with a complete thoracic traumatic spinal cord injury. I received an email from him while I was at work to my work email about how his progress had been at rehab. And I know that he had emailed some of the nursing team and other members of our team that were involved with his care as well. His progress was very significant. So when he left with us, we were using a Hoyer lift to transfer him out of bed. And in the email, he said that he was supervision for sit pivot transfers, which was huge progress. But the last sentence of his email was this: the work you do really does have the ability to change the course an individual is on and ultimately to change lives. And I think that this sentence applies to everyone in this room. So I believe that we all entered healthcare because we care about helping patients, and we value that. But sometimes I think it's easy to forget or to not give ourselves enough credit for what we're really capable of doing as therapists, as nurses, as healthcare professionals, which is changing lives. So I can stand here and say that this is the best practice and care for spinal cord injury survivors, but that's not what's going to make this our standard care, our standard practice. We need everyone as a team, our physicians, our nurses, our therapists, to work towards implementing these changes and ensure that our patients are receiving, the best care that we can do for them. For us to acknowledge and understand that our patients with spinal cord injury survivors are complex and have complex medical needs that is different than other patient populations that we serve. The work that we do throughout all settings, acute care, acute rehab, home health, outpatient, with these patients is assisting people who have gone a completely life-changing event be able to live their lives again. And sometimes that's achieving a pretty independent level, but sometimes it's not. And helping them adapt to what their new life is, what their new functional status is. So I think that we really need to give ourselves enough credit for what we do, because we're really capable of changing lives. And that's it. Are there any? And then I need to
questions you guys have?
Hold this.
So, Marlee, you talked about when a patient is suffering from autonomic dysreflexia, sitting them up at 90 degrees and monitoring their blood pressure every 3 to 5 minutes. So what happens if you can't get that under control? Mm-hmm. So remove the noxious stimuli that's causing it. And of course you're in constant contact with maybe Jim and behind me can answer that. What is the course of action that the physicians will take to get that under control before it does lead to death?
So luckily, the 2 times that I dealt with this, we were able to do the noxious stimuli. And I know I was with Marlene and Tara for one of them, that we were able to identify what the barrier is. Once it was a bowel, in my experience, once it was incontinence of bowel, and the other time a catheter was kinked. So we were able to identify that and to remove it. But to be honest, so I know that when we did this, we had contacted our medical team to know, so that, and I had briefly overheard them discussing what their plan was going to be if we couldn't do this and what medications they were going to use and order. But honestly, I'm not sure exactly what their standard protocol would be to use more vasopressors or to make sure that blood pressure was lowered. To be honest, I'm not exactly sure what the medications. I don't know if Ann or Jim, you could give more, not to put you on the spot. I don't know if you could give more of an answer, if you've ever had that happen. physician dependent.
Yeah, I think it would be physician dependent on what specifically is going to help that patient.
Mm-hmm.
Medications to lower the blood pressure immediately.
Mm-hmm. Would be what they would have to do. Mm-hmm. And that's why it's so important to kind of, I think when this happens, it's a situation where so many people are involved in it and you have to do stuff at the same time. So, it's not like you're going to say, okay, we're going to contact the physician. We're going to wait to see what, immediately we need to, when this is happening, we're yelling for nursing to come in, we're rolling the patient, we're checking them, we're sitting them up while someone else is also calling the physician team and making them aware as we're trying to identify the stimulus, because we know that in a matter of minutes, our patient's blood pressure can escalate to 200s, systolically, and then that's when they're going to be at risk for all of the adverse effects of this. I don't think there's any questions that popped up online too. I don't think so. Does anyone else have any questions or comments? Okay. Well, thank you for coming. I hope this was informative.
Make sure you sign out and make sure you send me an email for a quiz.